This is a little video about the biceps. It comes up commonly in patient questions. So if we look at this right shoulder, by right shoulder here, bi obviously meaning two, the biceps has two parts. One part of the bicep comes up and attaches over here to the coracoid bone, and that side over there is really never a problem. The other part of the biceps is a long, narrow tendon, which you can see right here, that goes in a groove and goes down and attaches to the inside of the shoulder on top of the glenoid or socket. Now, this is the one that can give us troubles. This other part of the biceps is not an issue. So with biceps, we commonly see a couple different scenarios. Occasionally, patients can rupture that long head of that biceps, and they'll have some asymmetry in the muscle here commonly that we call a Popeye change, so it looks a little more balled up. But the other part of the biceps that goes over to that coracoid is always there, so it's not a complete separation of the biceps. The other time that we see biceps problems is with rotator cuff problems, and the rotator cuff itself may be torn and need attention, but the biceps going up next to the rotator cuff may be partially torn or inflamed and need to be addressed as well. The natural history of biceps problems has been looked at through many studies. Biceps is an elbow flexor, and then also is involved in what we call supination, which is turning the palm up, which you might get, say, with a screwdriver or undoing a jar lid. So patients will say, well, if I rupture the biceps or the biceps is a problem, I won't be able to do those things. And remember, we still have part of the biceps attached. So at the end of the day, patients really can function well, even if that part of what we call the long head, that narrow one, is ruptured. They may have a cosmetic change. A small percentage might get a little cramping in the muscle if they try to do repetitive, forceful activities. But for the most part, patients can do what they want to do. And there are all kinds of examples of high-end people, even professional athletes, that have had that long head ruptured, and they return to their sport or their activity or rock climbing, and they can be very effective. When we have a patient that has a rupture, they're younger, they're more concerned about what that biceps function might be, we sometimes go in and repair that back down. And then in those patients with rotator cuff problems that were there really more for the rotator cuff, and we have to treat the biceps, then we may elect to do something to the biceps there as well. Now, sometimes what we do is called a tenotomy, and that's where we come in right here. We find the biceps and just release it from the shoulder. And then that way, when the arm moves, this biceps doesn't keep going back and forth. When it's attached to the socket, that biceps goes around the arm, kind of like a rope going through a pulley, and can be a problem in causing some of the pain and roughening and inflammation around the biceps. So if we release it and the biceps comes back here and simply doesn't move anymore, then that may be adequate to release somebody's pain. For other patients, we may do what we call a tenodesis. And what that means is we may release the biceps up by the glenoid or socket in there, and then we reattach it to the arm. And then when we reattach it, it now functions and doesn't move back and forth as the arm moves, so it alleviates that pain issue, but it keeps the biceps attached to the arm to help with any kind of function of the biceps or perhaps with the cosmetic example. Now, when we do a biceps tenodesis, where we tack it back down to the arm, we have to be careful post-op. And so that means sling, some sort of lack of use of the arm while the biceps heals in. If we are doing rotator cuff surgery, then of course that really doesn't change things much. But if we're not doing rotator cuff surgery and the only reason to be there is the biceps, then clearly if we release it up here doing the tenotomy, then we can get patients moving right away because there's no real rehabilitation worry. But if we do the tenodesis, then we have to be selective about what they can do with their elbow and arm, because we don't want to do undue load on how we have reattached it to the arm and potentially have that fail. So we have to go slow until that heals in. Now, this has been a brief video on some of the long head biceps issues that patients encounter. This is a complex issue that I can't cover all of the potential risks and complications in surgery and the other implications of whether you do or don't have surgery on the biceps, and that becomes an in-depth discussion with the surgeon.